With all these changes in a female from anatomical to decreased reserve, immunity markers, inflammatory mediators, but the two things which I will touch upon and where regenerative medicine can play a role in patients of endometriosis is the receptivity of the endometrium and the quality of the oocyte and the embryo. We know the etiopathogenesis that could be altered immune function, cytokine production, macrophages and NK cells because of inflammatory response, hormonal influence, mainly the estrogen role which leads in lesion survival and growth. So we have discussed all the conventional treatments from hormonal therapy, pain medication, surgery, but now we look at IUI, IVF, surrogacy if the uterus is really bad, but we now look at the regenerative medicine. Is stem cell the next step to help cure endometriosis? So stem cell regenerative medicine comprises of the stem cell, PRP, now we are coming out with scaffolds, exomes, VSLs, number of them. This is the simple PRP preparation which I am not going to detail, but it is got supraphysiologic concentration of growth factors and the molecules will be locally at the site of tissue injury which will intensify the healing effect, and the stem cells, which mainly what we are using is the bone marrow derived stem cell concentrate, but even adipose tissue, even menstrual blood now is upcoming, and umbilical cord is very good, but it is unfortunately not allowed in India. This is how we plan a patient. I'll be using, I'm just giving the idea of how we prepare the stem cells. We have an in-house government approved stem cell facility where from the bone marrow we take the stem cells, but a counseling that it is an experimental procedure, it's not going to harm, but it can help you, and we admit the patient after audiovisual consent, and we give at least an antibiotic 2 to 4 liters of oxygen for 30 minutes, vitamin C and glutathione, and then we take the patient and we take the bone marrow. How do I start the yes. So it is the anterior iliac crest or the posterior iliac crest. It is done under anesthesia, short DA. We don't want to give any pain to the patient. We expect at least 80 ml, but 30 to 60 ml is also a good enough quantity. And immediately when this the bone marrow is removed, it is sent to the stem cell lab where we prefer the manual method also or the separating unit. Nowadays we use more of the closed separation units that are available. What are the bone marrow derived stem cells? They are multipotent cells with self-renewal. They can mitigate to the repaired damaged tissue, which is known as the homing end, secrete lot of growth factors, produce anti-inflammatory cytokines, prevent fibrogenesis, promote angiogenesis, and hence can restore and enhance ovarian and endometrial function. The best advantage of this is that they do not raise any ethical concerns because they are autologous. They have limited immunomodulatory function, low immunogenicity and chemotaxis, and the risk of tumor formation is very, very minimal or none at all. This particular paper from Saha et al. Has shown that how there is a role of stem cell in various infertility patients, including the patients of endometriosis. This diagram has been explained that because of the inflammatory environment, there is poor oocyte quality, hormonal imbalance, and poor embryo quality and impaired uterine receptivity. What is affecting? There is always a controversy because sometimes a bad endometriosis patient can give a good oocyte, sometimes they are very bad, and the endometrial inflammation with progesterone resistance has been there to say that there is lower implantation rate. We started our stem cell therapy for ovarian reduced reserve, for premature ovarian insufficiency, and now we have extrapolated these indications to failed fertilization due to oocyte quality, lower fertilization, recurrent miscarriages when there is no other cause but low AMH, PCO patients also we have started more of PRP and endometriosis. In endometriosis we know there are fewer oocytes, lower embryo count, but still fertilization consistent across the endometriosis stage 1, 2, 3, 4 in most of the patients. For a good quality oocyte, we need a balance between the inflammation and sex hormones, There is a good antral follicle fluid, which is very, very important with the cytokines and immune cells. And the granulosa cells are the most important. But in endometriosis with local pelvic inflammation, dysregulation into the follicular microenvironment and the higher apoptotic incidence in the granulosa cells makes it difficult to get good embryo. This is the experiment in the red, where they found that the immune modulatory properties could also bring back the ovulation, the follicular genesis when they were given chemotherapy. They could restore it after being treated with the bone marrow derived stem cells. An experiment in the rabbit by Ella et al. They found that the bone marrow derived stem cells can restore ovarian functions by downregulating FSH, upregulating estrogen and VEGF, and that for good follicular genesis. So the stem cells or the PRP will go and home into the ovarian stem cell niche or nest, promoting angiogenesis, paracrine factors are improved, granulosa cells are improved. And now I'll come to the concept of what is ovarian stem cell nest. It is one of the major component of ovarian stem cell niche. It comprises of the granulosa, vascular endothelial cells and immunological relevant molecules. And when we do a stem cell therapy, we are trying to reduce the TNF-alpha anti-inflammatory, anti-fibrotic effect, and angiogenesis improves and follicular genesis also improves, especially there is pro-apoptotic properties for the granulosa cells and cell proliferation. So increase pool I will not say, but marginally, but yes, improve function and delay the ovarian consenescence. So there were preclinical studies where they have used this concept of ovarian niche, where stem cells were being used to promote the development of the remaining follicles within the ovaries, and these are number of literature, but not for endometriosis, any POI patients. Our experience, we have done so far 235 patients with bone marrow derived concentrate for ovarian rejuvenation, mainly for POI, but now we have included for endometriosis, PCOS also. And these are the some case reports for PCOS patient, endometriosis patient. This patient reported to us age 35, AMH 1.46, grade 4 endometriosis. First cycle failed elsewhere from Dehradun, and she had the reason given was low quality oocyte. So here we did the surgery. So living in a house where my son, who is a hardcore lab surgeon, and I am a hardcore IVF specialist, we are always at the loggerheads. But fortunately with my daughter-in-law around now, we are working hand in glove. He wants to operate first, I want to do the IVF first. So this particular patient, when she had a failed IVF before due to low oocyte quality, and they were kissing ovaries with huge endometrioma, we decided to go for the surgery because we didn't want to subject her to IVF again with the same result. And after the surgery, endometrioma was removed. With the same egg retrieval needle, we have injected in the cortex the bone marrow derived stem cells. So what we do is we just do the mononuclear cell count, which should be 10 to 15 million per ml, and we inject about 2 to ml in the cortex of each ovaries. So we did this in October. In 20 January she comes, we put her on 2 doses of long GnRH agonist depot, 3.75. She came for a cycle, we got 5 eggs, 5 embryos, 3 is transferred, and she is pregnant right now. This is another patient, again from UP. She had grade 4, 3 to 4 endometriosis. With severe pain she had come. We decided to do the surgery, and because we decided to do the surgery, we thought of also doing the bone marrow stem cells, because we know that it does not harm, but it can help. Can I get surgery? Yeah. Sorry. So here again there were huge endometriomas on both the sides. We did the surgery by removing the endometriomas, and again when we take the bone marrow derived concentrate, we also take the platelet rich plasma of the patient, and we see that the cells are cultured at least for some time in the platelet rich plasma. So our protocol is, after the bone marrow is taken, immediately the laparohysteroscopic surgery is started, and in the meanwhile in the stem cell lab, the stem cells are getting prepared. So we can see that the huge endometrioma was removed, and then we are injecting the bone marrow derived stem cells. Here you can easily easily see the ovarian cortex, because that is where there are remaining follicles there, and you can inject it precisely where you want it. And we also inject a little in the ovarian hilum also. So once this is done, we give the patient 2 months of GnRH depot agonist again, and then call the patient for IVF again. This was done in November 2022. Grade 3 to 4 endometriosis. This was the final picture. And she came with a low AMH again, but the depot was given. We got 1 egg in February. Again she was called in April. We got 2 eggs, and we did a fresh transfer. Why? Because we had already given agonist to both the patients prior to starting the stimulation. I agree it should be a frozen transfer. So this baby is already delivered, and we have our own publication in fertility in reproduction on the PRP in low ovarian reserve, where out of 45 we had 27 positive patients, and this is the data. And we have concluded that could be a new potential for low ovarian reserve. Now endometrial receptivity is also affected, and this endometrial receptivity, can stem cells or PRP help? And here we have got that this is the reason. So how stem cells help in endometrial receptivity? So there has been animal studies which has shown, this is the study, that it can stimulate growth factor, cell proliferation, enhance receptivity marker, increase endometrial thickness and cell marker expressions. So we are not sure whether it is the egg or the endometrium. So in our patients with severe endometriosis or adenomyosis, we try to do a PRP or stem cells when there is a very thin endometrium, because again they can regenerate into stromal cells, endothelial stem cells, epithelial progenitor cells, and because of immunomodulation and all this property of stem cells, there could be endometrial regeneration with improved endometrial receptivity. So methods of instillation is intrauterine, subendometrial, hysteroscopically, or directly into the uterine artery, spiral arterioles. If we are doing it, it's just like IUI, about 0.5 to 0.7 ml of PRP. Normally we don't use stem cells for this. It is done 2 to 8 days prior to an IUI or an IVF. Here we inject it subendometrially, hysteroscopically, with the same needle. We just pierce the endometrium and the myometrial junction, about 0.7 ml in all four uterine walls. And this is what we have followed the Carlos-Simon protocol, but slightly different. We have targeted the stem cell therapy for very thin endometrium when it is along with endometriosis or any other condition, because there are stem cell niches surrounding the spiral arterioles in the basalis layer. And this could be very scanty in such patients, but if we target directly over there, we can see that the stem cells can help home in and regenerate the niches which are there with the endometrium. And this is the procedure at our hospital. Once the bone marrow is removed, this is done in the cath lab, where through the femoral artery, we go to the opposite uterine artery, then we cannulate the uterine artery, and then we inject the stem cells which will go to the uterine artery spiral arterioles. We have confirmed this with fluorescent dye after this. Our interventional radiologist or cardiologist help us in doing this. So this procedure, we have published our first case report in the journal CERM, Clinical and Experimental Reproductive Medicine, and then we have published in Journal of Regenerative Medicine. We have given a pilot study of 12 patients with the outcome, and out of those 12 patients, one opted for surrogacy, 2 did not respond, because when we go to that uterine artery cannulation, sometimes due to severe endometritis, they are very stenosed and we cannot cannulate it. But so far we have done 41 patients with 16 pregnancies, and most of the patients in 22 and 23 are still trying. This last paper I'll go very fast, but this is the most important one, that a novel therapeutic approach for endometriosis using adipose-derived stem cell-derived conditioned medium, a new hope for endometriotic patients in improving fertility. So they have studied the mice which were endometriosis was created artificially, and then adipose-derived stem cell conditioned media was used, and they showed that the lesions shrink, it inhibited new ones, And the mesenchymal cells also showed anti-inflammatory effects. And we are worried that stem cells can spur endometriosis, but it was proved wrong that stem cells will not spur endometriosis. And they have found tissue regeneration. This is another paper. That paper was from Huang et al. Just in 2023. Frontier Endocrinology it was published. And this is the 2018 where they have found that the immune modulation with the mesenchymal stem cells can powerfully affect the immune system and reduce the chronic inflammation associated with endometriosis, helping in pain management. Scar tissue formation can be reduced, and also it has got pain relieving properties for decreasing in endometriosis. So these are some of the new literature that is coming up now for the stem cells in treatment of, especially we are more worried about pain and infertility in the patients of endometriosis. To conclude, I'll say that endometriosis definitely affects the reproductive organs. Along with it, there are so many other factors which is affecting. We have hormones, medical therapy, we have surgeries, we have IUI, IVF, but to improve the patient overall, stem cells could be a new modality for this type of treatment. And though this is innovative, but it has definitely generated scientific and clinical interest, understanding their unique properties for treating such a difficult under science that is endometriosis. Thank you so much. We are trying to segregate the endometriosis data, but definitely in poor ovarian reserve, we have seen that the patient had either failed cycle or a blighted ovum or a miscarriage, and when we did this PRP and waited, sometimes they even conceived naturally. Many have conceived naturally also if there was no other.
Because if it's a failed cycle elsewhere, when they change the unit, many times they conceive. The patients know about, they do a bit of doctor shopping. So it could be that you are a better IVF specialist and your lab is better. They were confounding very well.
What was the reason?
Yes.
If they get 13 eggs, just 2 embryos, and the male factor is normal, we can say, okay, the lab could be there. But if the egg quality specifically they have been told that there was brain related, factor related, not good egg quality, we should definitely look at it.
Is this only the number of egg? Will be any improvement in the image as well, or only we are focusing on the quality of oocytes? Or number will also be improved?
This will not, sometimes it improves AMH, sometimes the AMH remains the same. But mainly you need one good egg and one good embryo. So we concentrate more on that rather than seeing the numbers. When you get 35 individuals, something is nothing.
Madam, I have a question. So you did touch upon it in the last paper, but I didn't understand it. So as you mentioned, stem cells are multipotent cells. The same thing is introduced in the endometrium to improve the receptivity. The same is injected in the ovarian cortex. Now you did mention there was a risk or thought that it might spur endometriosis. So how does that, like the stem cells know to only stimulate the ovarian cortex, especially in cases of endometriosis and not the ectopic endometrial tissue?
Now we see that the adipose tissue stem cells are more potent for fibrosis, whereas bone marrow has a different problem. And what that was used in that paper was culture. Culture is not allowed still in India. After 3 passages, they got the conditioned media and they got the stem cells separately, and then they studied. Whereas the stem cell theory, which was there, that it promotes endometriosis, we were worried about that before using it here. That might be, it could flare up the disease rather than helping. But it is not so, has been proven by this particular study.
Thank you, ma'am. I think that's really a very good insight. My question would be, you're talking PRP or stem cell. I have seen PRP and been used, I've myself used it in pain endometrium. I've not seen a very drastic change, but in the stem cell I can believe should work better. So you've said all, but your data is showing very good outcomes of stem cell. So I don't know, is it either or is it?
So what it is like in young patients, where there is a marginal receptivity issue, lining is not very, and the patient has good platelet count initially. And when you prepare the platelets, it has to be 3.5 to 5 times higher. And then how you activate the platelets, it's very important, because the activation, whether you do it little mechanical, but there is also chemical activation. Within 15 minutes, the granules will start breaking and the growth factors will start releasing. And that is the time you instigate immediately for the best result. And I feel hysteroscopic subendometrial can even work for few months, whether intrauterine is just for that particular cycle. So the way you prepare the stem cell as a PRP and inject it. But if a patient has no platelet count, when you just harvest it after doing the procedure, it is less than 3.5 times. 1.5 has become just 2.5. That patient will not show any improvement. Older the patient, but sometimes in older patients, we have to weigh the age with the follicle, the action of this stem cells. So in older patients, we start within 4 weeks, but in younger patients, we definitely wait for 2 to 3 cycles.
Any particular complications you have come across using this specific method?
I can say that there are some patients who have not responded, but no case of ovarian abscess or no case of any lesions so far. That is the only thing that they may not respond. That is the only thing which is to be taken care of. And selecting the patient is also very important. If you go into the depth of it, you have to see that this is the right patient for this treatment.
Also, madam, do you always prefer a laparoscopy or also a transvaginal guided this thing? Because abscesses might be more common if you use a transvaginal route. So most of the videos laparoscopy.
And if it's stem cells, I 100% go for it. But if the patient is just had a laparoscopy and done, and I can easily visualize the ovaries, I won't subject. It's just 2 or 3. Now that my son is I know it's so simple that previously I used to outsource. So I would always counsel the patient to go for laparoscopy rather than transvaginal.
After the cystectomy is there?
After the cystectomy, otherwise when you do the cystectomy, it can come out. So you have to inject it also very drop by drop. You have to come 30 seconds with each drop. So it's not going to be very fast. And if the ovaries can be lifted, you can go trans-abdominally also with a big spinal needle. And there, the spillage of the bone marrow stem cell fluid is very, very minimal because you can monitor it very well with the spinal needle.
23 members filing into this.
Thank you. I think we can catch over lunch. Thank you very much, ma'am, for the brilliant session. Any other questions? We can catch over lunch. I think we are running out of time.